Good afternoon, everyone. It's 12 o'clock, and I think we will begin. Welcome to the Robson Report Training webinar. My name is Monica Poole, and I'm the Bourne Coordinator for LINs 1 and 2, who will be facilitating today's session along with Glenda Hicks, Bourne Coordinator for LINs 12 and 13, and Val Emerson, Administrative Assistant with Bourne, Ontario. I'm really pleased to share this hour with you and have the opportunity to introduce today's presenters. So Connie Bartley will be presenting first, and she's the Bourne Coordinator in the Greater Toronto Area, and as well coordinates the care for women referred to Mount Sinai whose pregnancy is complicated with a congenital anomaly. Following Connie's presentation about reporting using the Robson Cesarean Section classification, Carol Cameron, registered midwife and manager of the Childbirth and Children's Center at Markham Stouffville Hospital, and Sandy Marlowe, system facilitator and the Bourne local administrator from Markham Stouffville, will provide a few words about the Cesarean Section Reduction Initiative at Markham Stouffville. And Markham Stouffville was the pilot site for the Robson report. So we're delighted to have Carol and Sandy join us today. So a few housekeeping details before beginning today's presentation. Your lines have all been placed in mute. You can press *0 on your keypad at any time during the webinar if you are having issues connecting. There will be time for questions at the end of the presentation, and you can either type your question in the chat box on the left-hand side of your screen, or you may use the telephone queue by pressing 01 on your keypad to place your question in the queue and pressing 02 to remove your question. These instructions will be reviewed again at the end of the presentation. We will do our best to answer all questions today. If you would like to increase the size of the presentation, you can go to the auto box at the top in the middle of your screen and select full screen. Today's presentation will be audio taped and posted on the Bourne site in approximately 1 week. So what I'm going to do now is turn things over to Connie, and Connie's going to be the lead presenter for today's session. So over to you, Connie.
Thanks, Monica. What a wonderful introduction, and welcome everyone. Thank you for sharing your time with us this lunch hour. So we'll just move right on through the presentation and, as we said, have questions at the end. So we're going over the Robson Cesarean Section Classification Reporting Tool in the Bourne Information System. So just a quick look at our objectives for our seminar or webinar today. A brief overview of Bourne, Ontario, just a quick refresher of who we are and who are the founding members of Bourne. The Bourne Information System itself, commonly referred to as the BIS. Cesarean section rates, just a few comments about what's going on with C-sections, where we've come, what's happening now, and of course the Robson Cesarean Section classification itself, and an overview of the monitoring report in the Bourne Information System. So just a little quick note here that the presentation will be uploaded to the Bourne website and is being audio recorded today, as Monica mentioned, and it will be posted in approximately 1 week. And the Robson report itself will be available for review and goes live February 28th, so you can all start playing and seeing what's pulling through the reports for your specific organization. So Bourne is a PHIPAA registry, so we were granted registry status under the Personal Health and Information and Privacy Act in November of 2009, and this registry status affords Bourne the authority to collect, use, and disclose personal health information without consent for the purpose of facilitating or improving the provision of health care. So when Bourne was developed and the whole system and all the data elements were decided upon, they were all reviewed specifically under this criteria, and we also go under consistent monitoring of our adherence to the Privacy Act. So just the beginning of BORN is the integration of the 5 founding members, the Prenatal Screening Ontario, Fetal Alert Network, which dealt with congenital anomalies, NIDE, which is all labor and birth data from our hospitals and our midwifery midwiferys at the end, all of our labor and births in all of the hospitals in Ontario, newborn screening, and the midwifery program. So just a quick slide just to look at the a huge amount of data that's collected and housed within the BORN system, which is very exciting for Ontario and exciting for our improving of health care. So just looking at all of the births from our 109 birthing hospitals in Ontario and our 8,000 births from all 84 midwifery practice groups in Ontario, prenatal screening labs, so all of the samples from all 5 prenatal screening labs in the province, over 140,000 newborn screening results from Newborn Screening Ontario, 15 to 30% of births admitted to the NICU special care nursery, so that is a high number, and the mother-baby dyad is again looking at better practices to look at the possible reduction of some of the admissions in some centers, and prenatal and newborn screening follow-up results from all of the clinics. So it's a great resource and has a great depth of value for to be housed in all in one place. So just briefly reviewing our continuum, and for those of you that have been tuning into our webinars for quite some time will notice that the BORN information system is indeed growing. So we have our initial, across the top, mother continuum of care with prenatal screening all the way through to the NICU module. So wherever the patient experience or the patient touches on the system, if they have prenatal screening or if they have a suspected or confirmed congenital anomaly, et cetera, moving through labor, birth, postpartum, our midwifery care is also contained inside of this continuum. And then along the bottom, you'll see that fertility has been added at the front. So in January 2013, the Assisted Reproductive Technology Group has joined the BORN Information System, which is very exciting to have access to that knowledge and to marry it with all of the other components of the continuum. And along the bottom of the child continuum of care, there is the Healthy Baby, Healthy Children with the infant hearing program. So working with the Ministry of Children and Youth Services, we're looking at the feasibility of providing an additional source of information to the infant hearing program to identify children at risk for future hearing loss based on their perinatal experience and birth outcomes. Newborn Screening Ontario long-term follow-up, and the 18-month well baby. So we're working with primary care EMR vendors to integrate best practice tools into the 18-month well baby visit. So that's all very exciting for the system and for the growth and for care across the province. So just a brief little review about cesarean birth rates in the province, in the country, and in the world. So cesarean section rates have been increasing worldwide over the last few decades. So more than 1 in 4 babies are born by cesarean section. Most countries exceed the World Health Organization recommended rate of 15% of all deliveries. And in 2010 to 2011, the C-section rate in Canada reached 26.9%. So that's an increase from 17.6%. So it just prompts us to take a look as to why this is happening and just looking at practices and variables in which we could maybe make some improvement. A brief look at the country and the individual provinces. So you'll see Ontario sits at about 28.3% for our overall provincial cesarean section rate, a little bit higher from British Columbia on the coast and to Newfoundland on the east coast. So our Canadian national rate is 26.9%. That was provided to us from CI-HI data in 2010 to 2011. So factors affecting cesarean birth rates, there are many, and these are just a few. So the introduction of continuous fetal monitoring for laboring women, rising obesity rates, women and healthcare practitioners less willing to attempt vaginal births after cesarean section, and delayed childbearing. So our primates are often a little bit older now, and maternal requests. Risks associated with cesarean births. Mothers are exposed to increased risk during childbirth and for subsequent pregnancy, since this is major surgery, exposing them to increased infection rates, longer recovery times, possibly impeding breastfeeding and bonding with their newborn, satisfaction with the childbearing experience, and possibly contributing to an increase in postpartum depression rates, and of course an increased strain on the healthcare system. These are just a few, just to remind us of why this tool was developed and kind of why we're here today. So the Robson classification, there's a little nice quote here from Dr. Michael Robson himself. Cesarean section rates should no longer be thought of as being too high or too low, but rather whether they are appropriate or not after taking into consideration all the relevant information. So what is the Robson classification system? Robson is a standard classification system of 10 mutually exclusive and totally inclusive classification categories for cesarean section. So this is super important for our for being able to allow for the comparison between institutions, regions, and countries that adopt this classification system. So basically what this means is that each woman who has a cesarean birth fits only into one category. So there's no overlap at all. So then there's no skewing of the results. And this allows it to be comparable. So here is a look at the modified criteria from the Robson report, including all of our nulliparous women's, all different types of scenarios, to our multips as well, including you'll see spontaneous labor, augmentation of labor, induced labor, and cesarean sections prior to labor. So again, having this detail allows us to just take a look at the drivers of our cesarean section rates and groups where we can have an impact. You know, obviously in some of the groups of class 8 and class 9, etc., of multiple pregnancies or abnormal lives, we don't have a lot we can do there, but we can look at some of the other groups between classes 2 and 5, and just have a look at where we can maybe improve in the care that we're providing. So the Robson Cesarean Section Monitoring Report is contained in the Clinical Report section of the Born Information System. And when you log in, this is typical what you'll see of your login screen. In the top right-hand corner is the reporting tab, so on the navigation bar across the top. And second tab in is our clinical report, so you just give that a quick click. And this is just a quick slide to show that when you're choosing your parameters, so you'd look at what date ranges that you're looking to pull your information for your organization for. It can be as little as 1 month or several months at a time. You'll see the red circle. There's a new category to our reports saying expand rows. And this refers to whether you want the quarterly and monthly data opened when you pull the report or collapsed. So those little plus signs, sometimes they can be a little time consuming. And if you're wanting to see all of the data for the quarter and for the months that you've pulled, then if you just click yes to expand rows, then it will immediately drop out for you when you open the report. So here we are under our maternal newborn reports under the clinical reporting tab, and the Robson Cesarean Section Monitoring is at the bottom. All of our reports are listed in alphabetical order just for ease of finding them. If you log into the system and you can't see the Robson Cesarean Section Monitoring report under your profile, then you can just either contact your local admin or if you have access, to take a quick look to make sure that you've got the clinical reporting box checked under the hospital data analysis for clinical reports. Your board coordinator can also help with that as well if you're having trouble finding your access. So when you first pull the report, this is standard for all of our clinical reports. It just gives you a quick eyeball of where you sit, where data acknowledgement is concerned. So your data acknowledgement means that all of the data quality checks have been performed, and it just gives you reassurance that the numbers that you pull through your reports are accurate for your organization. So just having some caution if you are running any of our clinical reports on unacknowledged data, that this might not quite add up to what you might expect. It's always good practice to clean the data first and pull your reports after. So the first tab of the report here, just to note at the top right-hand corner, all of this data is test data, so we're not able to, as we do provincial webinars, to show real-time data for any of our hospitals. So just for ease of the presentation, some of the numbers are, might seem a little strange, but we've just used some test data here for our purposes today, just to give you the idea of how the report's constructed. So our first tab is the type of birth, and again at the top it always tells you what the report is. So this is the distribution of type of delivery by hospital of birth and other same-level care hospitals. And it also always reminds you of the months that you've pulled, that you've chosen or pulled for this particular point in time. On the left-hand side, it just tells you the type of birth, so vaginal birth, cesarean birth, and it gives you your totals at the bottom. Your hospital is always listed first, and if more than 3 of your comparator or same-level hospitals have acknowledged data, then you will see that those columns populated. If ever you pull a report and you don't see those columns for the comparator hospitals, it's because that less than 3 are likely acknowledged for that period of time. So here's a look. The next 2 slides are a little bit busy, so I'll try not to make you too dizzy by toggling between the 2. Because it is a 10 classification system, it's hard to show it all on one slide that you'd actually be able to see. So we've broken it out into 2 slides. So on the left-hand side, again at the top, it shows you the time frame in which you've pulled the report. And then on the left side, it just gives you each classification in the modified criteria. The first column gives you the number of cesarean sections. The total number of deliveries follows, your rate of cesarean section for your organization, the relative size of that group, and I'll talk a little bit more about that in a sec, and then the contribution of that particular classification to your overall cesarean birth rate. So the second slide continues and again gives your totals at the bottom for all of your 10 classifications under each of those particular columns. So I'm just going to slide back up to our first slide here. So you can see that you would have it would give you your total number of C-sections and then your total number of deliveries, and then obviously that gives you your percentage for your rate of your cesarean section for that time. The relative size of the group is an important one to keep an eye on clinically. So when you're getting started, you might notice that it's a little bit higher than maybe you might want, and you might institute some quality improvement initiatives to maybe bring that down a little bit. So this helps you to kind of figure out if your improvements are working, and what and also it also helps you figure out what your drivers of your C-sections are given each classification. Let me just see here what happened there. Sorry about that. And then you can look at the contribution to that particular classification to your overall rate on the far right-hand column. So quite simple, but just a few things to note about those columns and what they mean. So there are a couple of wonderful tools that have been integrated into this report. One of our first reports to contain hyperlinks. So this is the list of records for each classification. So on the left, each classification group for the Robson classification, and it shows you the ID types of the records that might be missing some of that contribute to the classification and also might be missing some data. So a little bit of a tool to help you get easier access to those records than we've had previously. So we have the hyperlinks in the report when you pull the report and stay live in the system. So what that means is if you pull the report into another format like Excel, you're pulling that information out of the Born Information System and the hyperlinks will no longer work. So you can just need to stay inside the system and in order for them to stay enabled. And you can see along the bottom here where it has some parameters. We've got your type of delivery, your presentation, parity, whether they were a previous cesarean delivery or not, and type of labor, number of fetuses, etc. And then it will give you the elements that are missing. So with ease, you can click on the hyperlink and be brought directly to the record. Enter the appropriate choice for that missing data element. Press submit again, and have your records that contribute to this completed.
Star one, right?
Yeah. So the type of missing data element also is shown in this format. So we have a few formats just to kind of give you an idea of what's happening. So this gives you a great snapshot for some of the pics here inside the report. And again, there is a hyperlink there that can take you directly to the record. This one in particular is great for a snapshot of what you might consistently be missing, and it also includes answers unknown. So this is a very helpful tool. Just if you're consistently missing one element, you might be able to drill down why that is, whether it's through manual entry or through an upload process. So here is also another. You click on the ID number and another hyperlink into the actual record. And this is the other table where this is a little bit more handy than just the first chart or the chart I showed you that just gave you the snapshot of the unknowns and what you might be missing. It'll take you directly to the record, and again, it just gives you the missing data elements, and so you know when you go in, you know exactly what to correct.
We've gotten 3 requests.
When you click the hyperlink, the record will show up, and just something to note as well is the record will show up behind your Robson report. So it's important when you're making these corrections just to minimize the Robson report and your record will show up. And you can just double check that the ID number is what you've chosen through the hyperlink, and you can go ahead and make your corrections or additions to your record and press submit. When you're moving through more than one record, so you may finish the corrections or additions to this record and hit the submit button and go back to your Robson report and click on another hyperlink, there will not be an obvious refresh. So just again noting that the ID number is correct to the record that you've chosen, and then make the corrections to the now second record and carry on.
Ridiculous. Like I love sharing it and everything, and I want to, but it's just like every time I turn around, right?
Hi, could everybody make sure you're on mute? We can hear conversations across the line. Thanks.
So just in conclusion, it's important for us to focus a little bit less on targeting a certain percentage or rate of cesarean delivery. The right number and percentage is still up for some debate, but more about understanding your population, what's happening within your organization itself. And this is what the Robson report allows for. The focus, it also allows us to focus on following best practice guidelines. So again, looking at those classifications in which we actually could change or improve the way that we're delivering care inside of our organizations and making a difference. And also, it allows for us to determine the most important contributors for our cesarean section rate. So it gives hospitals a place to begin, and this report is such an asset for your quality improvement toolkit. And then that way you can look at what's really happening with your care, and then target those areas in which you can actually measure. So clinically meaningful, feasible to measure, and actionable. And again, those classifications from 2 to 5 are really where these fit the best. So that's it for me for the formal part of our presentation, and I will allow Sandy Marlowe and Carol Cameron from Markham Stouffville, who've done extensive work with Robson criteria and pulling it manually for quite a long time in their institutions.
Great. Thank you, Connie. That was a wonderful presentation. So I think, as Connie mentioned, we do have Carol Cameron and Sandy Marlowe on the line. Are you there?
Yes, we are. Can you hear us?
Yeah, we can hear you fine. Thank you for taking time to join us. This is we're really thrilled to have you be a part of this webinar today. So anyway, we're going to turn it over to you for a few minutes and just for you to talk about your experience at Markham Stouffville.
Sure. So in 2011, we decided to get serious about tackling our cesarean section rate, and the place we started, one of the places we started, was to look at the buckets, I guess, for lack of a better word, where we were seeing the most cesareans happening. So in essence, while we were not formally using Robson, we were essentially doing that. So we knew what our rate of C-section was, and then we were just stratifying it by, the obvious indicators, like what was the indication, essentially. And then we went further. Was it in a multiparous population? Was it in a nullip? What was going on? So on and so forth. And what we quickly discovered, and I suspect that if a lot of people do this, they'll find similar results, was that our two biggest streams that made the most contribution to our cesarean section rate was the nulliparous population, a diagnosis of dystocia, and in the multip, a person with a history of a previous cesarean section. So when we stratified even further in the first group, we discovered that it was induction of labor. And so just as you said, we were then able to take a quality initiative to tackle both of those things. Sandy, I'm the clinical manager here right now. At the time, I was the head midwife, so it was a multidisciplinary team that worked on this. And Sandy is our born coordinator, so she is here, and she can talk about that part of it. Very much involved in looking at born and using it and using the data. So we're really, really excited that you are now producing a Robson that we can do, because we've kind of evolved to the point where the last 3 months, 4 months, we've been actually producing a Robson. And it's an extraordinary amount of work to do that yourself, right, to be plugging in all that data. So why don't you talk, Sandy, about what we did around the two buckets, like what was the quality things that we tackled?
So, as Carol said, it was multidisciplinary. So we involved the entire team to look at how we book our inductions and whether or not we're meeting the criteria for our post-date inductions. That was the first area that we looked at, and that had a profound effect on decreasing our cesarean section rate, just making sure that when we're booking the sections, the right people are booking them and that they're being booked for the indicated post-date induction at 41 plus 1 to 3 days.
And for the MULTIPs for the VBAC, we did a lot of things. I don't know how much detail you want me to get into what our QA stuff was, but we did a lot of patient education. We changed our information we gave out. We made sure everything reflected best practice. We initiated birth option sessions for women who've had previous sections, so they really got a very informed choice, facilitated discussion led by a midwife and now led by somebody else. And so we've done a lot of work, and we have brought our section rate down to 25%. Last month we came in around 24. We'd like to do better, and we will. And so Robson will allow us to do that because a couple of things. We can see where we can get the most. For example, we knew in the nulliparous it was dystocia. So then we stratified and knew it was induction. And then we knew we had inappropriate induction. So we kept going. So we fixed that problem. And we have fixed it. I mean, if you look at our the Bourne dashboard and see any, inappropriate inductions, you'll see a 0 or less than 1% coming up consistently for us now, whereas other hospitals are sitting still 20, 30%. So there's an issue there, right? But we also looked at like dystocia. So what's going on around management of labor? Like, are we doing everything right there? And we now know that 30% of our nullips who have a diagnosis of dystocia and end up having cesarean section, it's happening in second stage, 30%. So we've just initiated a whole new change management program in terms of how we manage second stage, and that we're all consistent, because what we found out is that everybody kind of does things a little bit differently. So that's in process right now. So we'll see what that does. So you can just keep chipping away at it, right? Because data is powerful. Knowledge is powerful. And Robson really allows you to do that. And then we actually sit around and discuss it at our interdisciplinary meetings, and then the departments of OB, division of midwifery, et cetera, discuss it. And we do things like open charts. I mean, so if we see that we had cesarean before labor, that's a bit of a flag, right? So what's going on there? So you look at the indication, and let's say there's previous. So we open those charts. It's easy now. It's great. We can just open it quickly and go, well, was it really a previa? And so I like the idea that it gets you away from just sort of setting an arbitrary rate, because nobody knows what the real rate is or should be. I don't think anybody really knows. But rather, are they all indicated? And, every month we can sit around a table and say, hey, these cesareans are all indicated, or, they're not, and we have some work to do. So that's what it's allowed us to do. So I'll stop there, and then if you guys have questions for Sandy or I.
Yeah, great. Well, thank you very much, and congratulations to you and your team at Markham Stouffville. That's very impressive. And we're delighted that some of the reports are going to help you in the future as well. So great. Thank you so much, and if you would stay on the line, because I'm sure that there will be questions. So what we will do now is that we'll, if you would please identify any questions that you might have in the chat box, and then we will check that. And Val, do you want to just review about the telephone queue?
Sure. Excuse me. If anyone has any questions they'd like to add, ask by telephone queue, what you can do is you can press 01 on your telephone keypad, and your phone will be placed in the queue, and I will have a chance to unmute you individually to ask your question. If you've noticed that somebody else has already asked your question and you would like to remove your question, please press 02 on your telephone keypad.
Great. Thank you, Val. So just see, if anyone has any questions, could they please either add them to the telephone queue or place them in the chat box. I don't see that there are any there now. Oh, yeah, here's one from Lake Ridge. And this is a question for Carol and Sandy. Interested to know who leads your birth options class now. We have considered this option at our institution, but not sure who would be the best health professional to lead the discussion.
Hi, it's Carol. Originally, it was a midwife who led the sessions, and I'll tell you why. We knew that we wanted to do a lot of work around messaging to women in the community about VBAC, and we wanted to use the best, literature and the best kind of material, and we wanted to use the right people, right? So when we thought of expertise, and we also thought of information that women needed to get, one of the things that everybody came to the conclusion of is that the amount of time that it takes to really do a proper counseling with a woman and her family or whoever's with her around options after cesarean section, VBAC versus, elective repeat cesarean, took time, and it did need to be interactive and so on and so forth. And so the expertise, it was felt, was probably in the midwifery group who had, well honed that. And that is not to say at all that nurses and physicians do not have that expertise, but just that it's been really well built up in the midwifery model because of the time that midwives have to spend with clients in the typical care model. So we extrapolated that, and we had a midwife lead the session. So it's very much a facilitated session. In other words, the women are really supposed to lead it, right? I mean, you kind of give them some information, and then they ask their questions. They talk about why they had their first cesarean section. Usually you'll just get the common themes coming out. We use a decision aid and so on and so forth and send them off. So we did that for a year and a half, and then the person who's leading it now actually is someone who's in a volunteer position, and is a perinatal nurse here, was for many, many years, and historically was a midwife in another country. So that's the way it's working right now. I think that in different settings you could do different things. I mean, I think that there's many people in our health discipline setting who could do a really good job of leading the session. Sometimes it's just a matter of, how do you make that happen? Like, how do you operationalize it? So,
great, thank you. Another question from Tammy LaRiche is, what do you recommend when women present requesting an elective cesarean?
You mean, and they haven't had a previous section? Or?
I think maybe Tammy, you could expand a bit more, but it's addressing the issue of maternal request.
It's not really a significant issue for us. I wouldn't say it never ever happens, but it's not an issue that a woman with no indication will come and request a cesarean section. I don't know if that's something that you find in your population, but it isn't here. And those women could be invited to go to the session anyway, even if they haven't had a previous section, because they get the pros and cons and they get the risks of surgery versus the risk-benefit of vaginal delivery. But it really isn't I don't really find it's been an issue for us. Have you?
No, we get it.
Another question is, how do you go about booking your induction? Do you use Bishop Score, and what type of booking system are you using?
We use Bishop Score. We have a form. So essentially the process is this. If you are a primary care provider and you want to book an induction, there's a form you fill out which includes the Bishop Score, includes the indication, and it's based on the SOGC induction of labor timeline. So is it an urgent induction? Can it wait up to 4 days? Should it be done within 24, so on and so forth? Obviously, urgent inductions, like, somebody has a biophysical and there's an indication to get right away, we're not necessarily going through that process. But from the office, you fill that out. Most common indication is post-date. So you have to clearly fill the form out. There's a consent form that the woman is given, including an information booklet. That has to be given in, signed by the health care provider and the woman, that you reviewed all the risks of induction, and that the woman knows that if it's an elective procedure that it may not happen on the day that is agreed to, because it is an elective procedure. And it outlines the process for her, where to go, and so on and so forth. It's faxed into the floor. We don't really entertain them until 41 weeks. We don't really want to see them until then. We won't deal with them until then if it's for post dates. And then when it arrives, it's basically reviewed by, in our case, it'll be our facilitating nurse, which you may call a charge nurse or head nurse or something, and the obstetrician who's on call that day. So it won't necessarily be his or her patient. And then if it's appropriate, so if the induction is in fact post dates, then it's booked, and then that is communicated to the woman from the floor, and verification back to the primary care provider.
Great. So a question has come, Carol, is that would you be willing to share the form?
Sure.
Okay, so we'll talk to you then about how then we can distribute that.
Yeah, it's really the process. I mean, the form, yes, we can share the form. You have to come up with the process that works for you, and then develop your form, right?
Great. Okay, so another question is, this is just jumping around a little bit, do you screen at all for shoulder dystocia?
Okay, we don't in the, you're talking to a manager, right? Okay, but if you're asking if the clinician screen for shoulder dystocia, I'm not sure what you mean. Do you mean based on history, based on things that would indicate that the woman would be higher risk for shoulder dystocia? I mean, practitioners do that, yes. Maybe you need to flesh that question out a little bit more for me.
I think so as well. So maybe we'll ask for a little bit more detail on that. Another question is when you review the cesarean section, do you have any members of the team disagree with any of the decisions? And who has, let me just see. When you review the cesarean section, do you have any members of the team disagree with your decision, and who has the last say?
Okay, so we're not doing it. We do it retrospectively, not prospectively. So that's something we've talked about. We've talked about if a cesarean section is being booked for, whatever reason, that there could be a second reviewer. We haven't moved to do that. We've talked about it. There is some literature on that it does bring down your cesarean section rates. There's a couple of nice studies on that. We have not done that. We do it retrospectively. So if you're asking me when we sit and look at our cesarean section rate and the indications if we have disagreement, I would say no, we don't really. We sometimes will point out some things that, if you were to find, for example, that a woman was booked for a previa and the placenta was, 2.5 centimeters away from the cervical os at term, there would be a very robust discussion about that, believe me, right? Because, most people would say that would not have, that it is not a previa. So those kind of things have happened, and those are good things, right? Those are good discussions to have. But no, I mean, we're pretty well finding that they meet the criteria, but we have work to do, right? So, we've got a lot of women who have cesarean section because of dissociative labor. So what are we doing there, right? Can we have some discussion about that? I don't know if that answered your question, but...
Yeah, I think that answered the question, and these are all good learning opportunities. Andy, I'll just turn things over to Val to see if there happens to be anything in the telephone queue.
Hi, Monica. No, there are no questions in the queue at the moment. Hello?
Hello?
Hi, sorry, I'm not sure if you heard me. There's no questions in the queue at the moment.
No questions in the queue. Okay, thank you, Val.
No problem.
Are there any other questions? Is there any other questions that you would like further expanded if your question wasn't answered? just wait for a couple of minutes. Glenda, you're on the line. Do you have any questions?
No, I don't, but thanks so much to our guests from Markham Stouffville to have generated such lively discussion, and it looks like there's a real desire to have your contact coordinates. So if you wouldn't mind just letting people know if you're interested in people connecting with you, and if you'd also send your forums to maybe Tammy Boudoir, who could send to the coordinator team, then we could disseminate as well if you're interested in sharing it.
Yeah, Tammy, you could maybe coordinate with Sandy, and we don't mind sending you a scanned copy of the form. In terms of if hospitals want to really get into nitty-gritty and want someone to talk to them about the whole process, I think that's a different discussion. But because it's not, it frankly takes time and energy, which we're willing to do, but we'd have to sort of think about how that would happen. But the form, yeah, that's pretty straightforward. Okay?
Great. So I don't think we have any other questions. And so we'll follow up on those few tasks. So I think that we will be, it's 15 minutes to 1 o'clock, so we'll be able to leave a little bit early. So on behalf, I would like to sincerely thank Carol and Sandy for adding this presentation today, and to thank you to Connie for setting the tone and doing such a lovely job of reviewing the Robson report. And if any of the sites, once they start using the Robson report on February 28th, any questions that you might have about the report, please do not hesitate to contact your coordinator. I hope everyone has an enjoyable rest of the day, and thank you for taking time today to share your time to learn about this webinar. Thanks again, and everybody have a safe trip if you're in the snow country for later today. Thank you.
Thank you.